Good morning, students. Please check yourself who is present on our lecture. And we start. Okay, the topic of our lecture today: acute otitis media and mastoiditis. First of all, let's start on some important fact in anatomy of the middle ear. The ear commonly is divided by three big parts: external ear, which includes pinna and external auditory canal; middle ear, which consists of cavum tympani, eustachian tube, and mastoid process; and internal ear, which is present by labyrinth. And mostly the middle ear is affected by the infection. So we stop on anatomy of this part. The middle ear it's a cavum which connects from the one side with the eustachian tube, and eustachian tube opens in the nasopharynx, and from the other side it connects with the mastoid process through editus ad antrum. Antrum is the biggest cell of the mastoid process. And middle ear lined by mucous membrane. It is extending from medial surface of tympanic membrane to cochlear promontory of internal ear. It lies in between external ear and inner ear. It is shaped like a biconcave disc. The vertical and anterior-posterior diameters are 15 millimeters. Transverse diameter is 6 millimeters at upper part, 2 millimeters at the center, and 4 millimeters at the lower part. Tympanic cavity has 6 walls: upper roof, inferior floor, anterior wall, posterior wall, medial wall, which is present by labyrinth, lateral wall, which is present by the tympanic membrane. And it is divided on 4 chambers: mesotympanum, the middle part, epitympanum, the upper part, or atic are the name of this part, hypotympanum, inferior part, and the posterior tympanum. It's a part which connects with the mastoid process. Contents of tympanum. First of all, it's air, but other structures are ossicles, 3 ossicles which connects each other from tympanic membrane to the oval window. Tympanic plexus, which consists of 5 nerves, intratympanic muscles, 2 muscles are the tensor tympani and the stapedium muscles. Chorda tympani nerve, it's a branch of the facial nerve, and lots of ligaments and arteries and veins. And so we may imagine the tympanic membrane like a cube, and every wall has some relations. Look at this scheme, and we understand that the lateral wall, it's a tympanic membrane with malleus and incus. Chorda tympani also transfers this part. Upper part, upper wall, it's a tegment tympani. Tegment tympani, and geniculate ganglion, it's also near this wall. And also Reich produced by lateral semicircular canal. Anterior wall has a auditory tube and relations to the internal carotid artery. Middle wall has a auditory tympanic plexus, promontory, round windows, and oval windows with stapes. And inferior wall has relations to the internal jugular vein. And so we see that the anteriorly nasal tympanic communication to the nasopharynx through the eustachian tube. Posteriorly to the mastoid tantrum through the adytus. Walls of the tympanum roof or tegmental wall, it separates the tympanum from the middle cranial fossa by a thin bony plate known as a tegment tympani. It's a very important because it's a place which the infection may spread to the brain. Phloem or jugular wall, the middle ear cavity, is separated from the jugular bulb by a thin bony plate also. It's the one more scheme. And the tympanic membrane contains 3 ossicles, malleus, incus, and stapes, 2 muscles, tensor tympani and stapedius, 6 sets of arteries, and 4 sets of nerves. During examination of the tympanic membrane, we may understand the condition of the middle ear. So it's very important to know how it's look at the normal. So we can see some features of the tympanic, the normal view of the tympanic membrane. First of all, it's a cone of light is reflected from the anterior inferior quadrant of the membrane. Beneath the membrane, the handle of malleus is seen as a yellow streak extending from the center upward to forward. A white prominence in the upper part of the stick represents the lateral processes of the malleus. The long processes of incus is often seen as a white streak behind and parallel to the upper part of the handle of malleus. Deep relations of tympanic membrane. Anterior inferior quadrants, it's a carotid canal. Anterior superior quadrant, tympanic opening of the auditor tube. Posterior superior quadrant, long process of incus, stapes and fenestra vestibuli. Posterior inferior quadrants, promontory and fenestra cochlea. So all these features is presented on the picture. And tympanic cone of light, manubrium of malleus, umbo, lateral process of malleus, anterior malleus fold, posterior malleus fold, long crus of incus, and tympanic membrane has two parts. Pars stensa, the biggest, bigger, and small pars flaccida. They have different structure. The pars stensa consists of 3 layers and has a middle fibrous layers. And the pars flaccida hasn't these middle layers, so it consists only 2 layers external, it's epidermis, and internal mucosa. It's a inner part of the tympanic membrane. And so we can see the same structure from the other side. Also manubrium of the malleus, lateral process of malleus, tendon of tensor tympani muscles, stapes in oval windows, long crus of incus, chorda tympani nerve, tender osteopedius, and round window. And very important communications of the tympanic cavity, because the infection from this part may spread to the other structures and inflammate it. It's a complications. Anterior middle ear cavity communicates with eustachian tube. It's about 3 and 5 centimeters in length, which connects the middle ear with nasopharynx. The outer third of this is a bony that adjoins with the middle ear. The inner two-thirds is legions and leads into nasopharynx. In adults, the tube is obliquely placed, whereas in infants it's short, wide, horizontally placed, so nasopharyngeal infection easily spread to the middle ear in infants, and acute otitis media also very often diseases in a young ear. Posteriorly middle ear cavity communicates with mastoid antrum through adytus. Adytus edantrum, a short canal connecting epitympanum with mastoid antrum. Mastoid antrum is the largest ear cells in mastoid bone. So, acute purulent otitis media disease, local manifestation of which is acute purulent inflammation of the mucous membrane of airfarous cavities of middle ear. Otitis media, a infection or inflammation, is the most common childhood condition for which antibiotics are prescribed. Acute otitis media is most common between 6 and 24 months of age. By age 3, more than 80% of children have been diagnosed. So you see, it's a very actually, especially for child. Etiology and epidemiology. 90% of children suffer from acute media effusion before school age. From 30 to 40% of children with recurrent otitis media. 5–10% last greater than 1 year. Etiology, the poor eustachian tube and destroy their function, which led to the spread infection from the nasopharynx and inflammatory response following acute otitis media. The more commonly microorganisms which may be caused by acute otitis media are Streptococcus pneumonia, Haemophilus influenza, Moraxella catarrhalis, and group A Streptococcus, common in older children, more frequently associated with the perforated tympanic membrane. And so we understand that the more commonly penetration infection to the middle ear is rhinotubal way from the eustachian tube. Bacteria or viruses from the throat can travel to the middle ear, causing otitis media. But sometimes the infection may come through the tympanic membrane, causing for trauma, direct trauma, and less, but sometimes it may be a hematogenic way. Bacterial invasion of middle ear led to the acute otitis media, catarrhal inflammation. Sometimes to this condition may be led other diseases, other conditions. First of all, it's dysfunction of the eustachian tube, which led to the negative middle ear pressure. It may be because of the adenoids, for example, in children, or barotrauma, and long period of the negative pressure in the middle ear led to the penetration plasma to the middle ear and exudates starts in a serious character in the middle ear. So it will be otitis media, acute otitis media with effusion. So you see that it may be some different form of the acute otitis media because of the different stages of the pathological process. Due to inflammation, eustachian tube becomes inflamed and blocked. As an infection progresses, the fluid pressure can cause the eardrum to bulge outward, and we can see it due to otoscopy. Pressure on eardrum and fluid restricts the movements of the bones of the middle ear, which impair hearing, and eardrum is instantly stretched inward, causing pain. So, due to the same pathological process, we can see symptoms of the acute otitis media. It's a pain in the ear, it's a decrease of the hearing, increase the temperature, often in children, and symptoms of intoxication. Some predisposing factors for acute periodic otitis media may be general and local. In general, decrease of reactivity of organism, supercooling, cold climate, inferable common and industrial factors, not being breastfed, recent illness of any type, low resistance of the body to infection. Genetic factors susceptible to infection may run in families. Changes in attitude of climate. And local inflammation into nasal cavity, paranasal sinuses, nasopharynx. Surgical intervention into nasal cavity, paranasal sinuses, nasopharynx. Focus anterior and posterior packing of the nose. Very important type of the mastoid process. Changes in the middle ear after transferred diseases. Pathogenesis. Adenoids very often involve either acute infection, maybe bacterial or viruses, and lead to the eustachian tube dysfunction, ciliary dysfunction, and it's impaired mucus clearance. Due to inflammation, a lot of inflammation cytokines led to the mucin upregulation and viscous fluid in the middle ear. It's also impaired mucus clearance. Some other external factors led to the inflammation cytokine, biofilms, allergy, and reflux. So a lot of factors may lead to the inflammation in the middle ear, you see, and led finally to the acute otitis media. For example, this scheme show us where the tobacco smoke, Down syndrome, and Pierre Robin, age from 6 to 16 months, lack of immunization, lack of breastfeeding, daycare, more than 4 children. And finally, all this pathological process led to the symptoms: fever, otalgia, and bulging tympanic membrane due to otoscopy, erythema of the tympanic membrane, sometimes bullosis meningitis, yellow or white pus behind the tympanic membrane, loss of the tympanic membrane landmarks, like a handle of Malleus, light reflex, and all that leads to the fussy and poor feeding. And the most diagnostic sign of acute otitis media is a bulging of the tympanic membrane. So otoscopy is a very important method which you may to do. Stage of the clinical cause of the acute purulent otitis media. The first one is development of the inflammation from 1 to 3 days. The second, perforated from 4 to 7 days. The third, reparative, healing, involution of the diseases after perforation from 7 to 10 days. And they correspond to the clinical cause. Development of the inflammation, augmentation of symptoms till perforation, duration from 2 to 3 days, and the symptoms when patient feel pain in the ear, especially during the nights, irradiate into the teeth or temple, decrease of the hearing, a conductive type disorder, increase of the body temperature till 38-39 degrees, sensation of stiffness in the ear, noise, pain during the palpation of the mastoid, sometimes may be present like reaction of the periosteum and the inflammation. And so during the first stage, we may reveal otoscopic picture, tympanic membrane of person with the 12 hours of ear pain, slight tympanic membrane bulge, and slight meniscus of purulent effusion and bottom of tympanic membrane. Reproduced with permission from Isaacson, the natural history of a treated episode of acute otitis media. You see the picture, the photo, and the classical view of the otitis media. Also, you may add your diagnosis, tympanogram, and we see the B-type flat curve and conductive type of the hearing loss on an audiogram. The second stage, a perforated stage, reveals perforation of the tympanic membrane. Fissured perforation is in the anterior inferior quadrant. Purulent discharge from the ear are present on this stage. It's a main symptom of this stage, and pain disappears. Decrease of the body temperature and the condition of the patient start better because the symptoms of intoxication also decrease. And the third stage accompanies with the decrease of the inflammation, purulent discharge stops, hyperemia of the tympanic membrane disappears, perforation, healing, and hearing restores. Hearing restores. So, after correct diagnosis, you prescribe the treatment of the acute purulent otitis media. First of all, it's an antibacterial therapy. The antibiotics which we may apply is semi-synthetic penicillins, macrolides, cephalosporin, quinolones. But we should remember that ototoxic antibiotics from the aminoglycosides group must not be prescribed in acute otitis media. And the first line for prescribing of the antibiotics today are amoxicillin clavulanate, and erythromycin-based sulfasalazole. No, and sometimes other antibiotics also may be chosen. cefuroxime, cefprazil, cephalosporin, and macrolide, azithromycin, clarithromycin, sometimes clindamycin. The second, it's anti-inflammatory drugs, non-steroidal anti-inflammatory medicine to relieve the pain. The third, vasoconstrictive nasal drops to normalize eustachian tube work and drainage of the middle ear. And local treatment you also may apply through the external acousticus meatus. During the first stage, ear drops Otinum, Otipax, Polydexa, Sofradex, Genadex. Sometimes we may perform paracentesis, surgical ambulance treatment, paracentesis of the tympanic membrane. During the second stage, perforated stage, after ear toilet, instill aqueous solutions of the antibiotics and antiseptics, Ciprodex, for example, or something other. During the third stage, rehabilitation of the auditory function, we may apply pneumomassage of the tympanic membrane by Ziegler's instruments, eustachian tubal insufflation by Politzers, or through the metallic catheter, catheterization of the eustachian tube to normalize the view of the tympanic membrane and hearing in patient. In treating ear infection with antibiotics, topical deliveries has a number of advantages over systemic delivery. So, in first stage, in the catheteral stage, we may start from topical ear drops without systemic antibiotics, and it may help also. These advantages include the following: a vastly higher concentration of antibiotics can be delivered to the site of infection. Medications delivered topically have no systemic effects. Topical delivery allows alteration of the local microenvironment. Topical medications are usually less expensive than comparable systemic medications. And sometimes we may add hyposensitization drugs, antihistamines, anti-inflammatory drugs, and physiotherapeutic procedures. Surgery, which use in case of the acute otitis media, can be divided into the three following related procedures: tympanocentesis or paracentesis of the tympanic membrane, myringotomy with insertion of a ventilating tube or grommet tube. The first one, paracentesis, its incision of the eardrum performs in its posterior or inferior quadrants with the special paracentesis needle under meatotympanic anesthesia. Tympanocentesis should be performed in the following patient with acute otitis media: neonates who are younger than 6 weeks and therefore are more likely to have an initial of more invasive pathogen. immunosuppressed or immunocompromised patients, patients in whom adequate antimicrobiological treatment has failed and who continue to show signs of local or systemic sepsis, patient with complications that requires a culture for adequate therapy. So, indications for myringotomy, the next. In case of acute suppurative otitis media, it's a bulging of the tympanic membrane about to perforate, or small or high perforation insufficient to drain the pus. In children with fever, diarrhea, and vomiting, because the symptoms may show the meningism with cranial or intracranial complications, with persistence of pain and fever for 24 hours after treatment. And sometimes this procedure useful in secretory otitis media to drain the middle ear and to put Grommet's tube. In case of otitic barotrauma, to drain fluid out and to let air into the middle ear and normalize pressure. And in association with cortical mastoidectomy to drain the middle ear after operation. So this picture shows us one of the type paracentesis which you need for the insert the grommet tube. And in incorrect place for paracentesis, you may affect other structure in the middle ear. What are they? Incus and stap connection, facial nerve, round windows, jugular bulb. So it's a very nice method for treatment, but sometimes it may lead to the complication. And acute otitis media in infants vary actually. The rate of acute otitis in infancy and early childhood is much higher than in adult age. The high incidence of middle ear diseases in infants is usually regarded as a link with the remnants of embryonic myxoid tissue filling the middle ear cavity and most susceptible to suppuration caused by the entrance of infectious germs through the eustachian tube, which is wider, more horizontal, and shorter than in adults. As for tympanic membrane in infants, it is more thick than in adults. Because of this fact, perforation occurs during the late periods of disease. So really, the picture shows us the predisposing factors which led to the more often incident of acute otitis media in infants. Eustachian tube, shorter, more horizontal, and wider. Adults has anterior part 2/3 cartilaginous, and it's longer so that and the post 1/3 bony, 45 degrees angle, isthmus angle, prevent coming infection in adults, but in children it has more strict direction. Isthmus 1-2 millimeters in infants and nasopharyngeal orifice 8-9 millimeters. And in adults, orifice 4-5 millimeters. Oh, sorry, it's adults, and in children, orifice smaller, so that the drainage is difficult for this age. And important structure of the mastoid process. In infants, it only starts to development, so mastoid process hasn't wide ear cavities and has only antrum, so it's not performs protecting function in infants. What about symptoms in infants? Acute otitis in infants passed through the same stage as in adults. Since acute otitis in infants show no adequate symptoms, it is often difficult to diagnose. Usually, meningeal symptoms are to be found, such as stiff neck, vomiting, coma, and convulsions, known collectively as a meningism. Meningism is irritate of the meninges of the brain without inflammation, and it may be present in infants because of non-completely close connection between bones. Treatment in infant acute otitis in infants is managed in the same way as in adults. But we talked about it before, they require very often paracentesis of the tympanic membrane because of the drainage. So for the infants, it's more commonly to apply surgical method paracentesis of the tympanic membrane and hospitalization to the ENT department, because they has higher risk of intracranial and local complications. And also we should know peculiarities of the some other forms of the acute purulent otitis media. For example, influenza. Hemorrhagic inflammation with necrosis is typical for this infection. 2-3 hemorrhagic vesicles, bulla, on the tympanic membrane and under epidermis of the external acoustic meatus are seen. In 1-2 days, bullas disappear. On their place remains blackish crust. Hemorrhagic exudates from the ear are seen. Often sensorineural hearing loss develops, and it requires quickly treatment in this case, immediately treatment. So treatment in this case, like usually antibacterial therapy, but when bullas reach big dimension, they have been opened by the paracentesis needle. You may apply in this case because the increase of the bulla led to very severe pain. Under measles and scarlet fever, we can abuse necrotic forms. Scarlet fever led to the necrotic otitis, which develops during the first days of septotoxic form of the diseases. Pus is rather thick with stinking odor. Destruction of the tympanic membrane, mucous membrane, ear ossicles develops. Due to severe general condition and nerve-ending lesion in the eardrum, pain syndrome is absent in this case, but destruction very severe, paradox in this form. And this form led to some more seriously complications, intracranial complications, meningitis, abscesses of the cerebrum and cerebellum, thrombosis of the sigmoid sinus and the sepsis, and labyrinthitis. Treatment the same, antibacterial therapy and prevention all these complications. Measles. First sign of inflammation of the middle ear developed during late period of the disease, along with the complications from the part of the larynx, bronchi and lungs. Perforation of the eardrum is sizable. Inflammation occurs in the middle ear is long-term. Complications from the part of the mastoid are seen. Treatment, antibacterial therapy also, and correct the duration of this disease and prevent or treatment complication. So we see that there are a lot of complications, maybe due to acute otitis media. They are divided on two big groups: infratemporal infections and intracranial infections. Intracranial temporal infections are present mastoiditis, facial nerve palsy, acute labyrinthitis, petrositis, acute necrotic otitis, and finally it may lead to the chronic otitis media. Intracranial infections are meningitis, encephalitis, brain abscess, subarachnoid abscess, subdural abscess, sigmoid sinus thrombosis. And today we stop on one complication of the acute otitis media, mastoiditis. Mastoiditis is the acute purulent inflammation of cellular system of mastoid. And they are related to the head under the pinna. It's a place of the relations of the mastoid process. So, due to examination of the patient, pay attention to the external view of the pinna and post-auricle area. You may palpate this part because this part reveals sensitization, pain, and fluctuation. So, external view of the mastoid process inflammation also may be seen during examination of the patient. Causes of development of mastoiditis: high virulence of infection, decrease of reactivity of organism, improper treatment of acute purulent otitis media, bad drainage of exudate from the middle ear cavity, from the tympanic membrane and mastoid ear cells, structure of the mastoid, mostly under pneumatic type. Clinical features of mastoiditis. Usually in adults, it develops at the 2-3 weeks of course of the acute purulent otitis media. In children, it may be early. Age of the patient is important. In children, 3-7 years proceeds rapidly. In elderly age, forms slowly, symptoms are not evident. Pain in the mastoid region, independent or under pressure on the site or apex of mastoid. Headaches, especially at night. Decrease of hearing, ear noise. Infiltration of mastoid soft tissues, smoothing of postauricular fold, hyperemia of the skin about it, protuberance of auricle anteriorly. Very important symptom. Paying attention to the asymmetry of the face of the patient, and protuberance of auricle anteriorly, it's pathognomical symptom of mastoiditis. Hyperemia and infiltration of the tympanic membrane and other signs of the acute otitis media usually accompanies the mastoiditis, because the mastoiditis is a complication of the acute otitis media. Development of the subperiosteal abscess, it's maybe stage of the formation of the mastoiditis. And in this case, you may palpate and reveals fluctuation of the post-auricular area. And in some diagnostic procedure, we may perform puncture of this area. Luminal narrowing of external acousticus meatus due to displacement of posterior superior wall bony part, Schwarz symptom. It reveals due to otoscopy. And inflammation mostly localized in the bony part. Paying attention of the bony part, its relation of the mastoid process. Profuse purulent discharge from the ear, symptom of reservoir, objective and basic symptoms. It show that there are a lot of purulent effusion in a middle ear and mastoid process. Middle ear cavum, tympanic cavity, has the volume only 1 centimeter in cube, not a very big volume. But if you see a lot of purulent discharge, we understand that they are from mastoid process, which has a lot of ear cells and connect this discharge. So these symptoms of reservoir really very important for diagnostic of mastoiditis. Prolonged fever, paying attention to this symptom, or fever may disappear and after some days return. General weakness, malaise. And the blood changes, leukocytosis, shift of the hemogram to the left, increase of erythrocyte sedimentation rate, and positive high level of C protein. So symptom of the inflammation in a blood present. So its picture show us a type of diagnostic of the mastoiditis. First of all, it's a external examination. We reveal asymmetry of the ear, displacement of the pinna, inflammation, oedematosis and hyperemia of the post-auricular area, mastoid area, and palpation may reveal the pain in this region and fluctuating sometimes. Then you examine the tympanic membrane by the otoscopy and reveals other symptoms of mastoiditis. It's a hyperemia of the tympanic membrane and narrowing of the external acousticus meatus because of the inflammation, installation of the bony part of the posterior superior wall of the external acousticus meatus, pathognomical sign. And sometimes you may reveal purulent discharge. Usually we remove it by the ear toilet, but if they very quickly comes out to the lumen, it's a reservoir symptom, also pathognomical sign of mastoiditis. And in some difficult cases, we may apply X-ray examination, and gold standard it will be computer tomography of the bony part of the brain, and we pay attention to the mastoid process, compare it with the other sign and see no absent of the ear like in normal view and the present fluid in this area. Also, you may relieve a purulent discharge, perforation of the tympanic membrane, and it confirm your diagnosis. But sometimes maybe some atypical forms of mastoiditis, which is difficult for early diagnostic, and also we should know about them. If inflammation spreads on the zygomatic process of maxilla, it is called zygomatic abscess, or if on the squama of the temporal bone, squamitis. And due to examination, you may reveal changes in this area of the temporal bone, edema, hyperemia of these areas may be fluctuation sometimes in this area. Sometimes the process involves petrosus part of temporal bone and led to the petrositis. It occurs in the classic triad of Gradenigo, that is, retroorbital pain, abducens paralysis, and ipsilateral acute or chronic otitis media. Petrositis may occur in a sclerotic or dipleotic petrosus apex. Diagnosis of petrositis, zygomatic abscess, and squammitis is made in a similar fashion to that of mastoiditis, with the additional symptoms of retroorbital pain or abducens paralysis. And one more type of the atypical form, it's a basalt abscess, the formation of the abscess on apex of the mastoid process. And in this case, you may reveal pain during palpation of the neck in this case. So in case of the atypical forms, we usually need additional examination, and in this case very useful will be computer tomography of the temporal bone and reveals the specific symptom and spreading inflammation to the other parts from the mastoid process to the other parts of the temporal bone. Also, you may reveal form of the inflammation and find abscess of this specific zone. And in case of atypical forms, the patient requires only surgical treatment. Treatment of mastoiditis may be conservative and surgical. Conservative treatment starts from the paracentesis of the tympanic membrane and antibiotic therapy, and usually we connect some antibiotics from other groups and perform ear toilet every day or 2 times a day and decrease symptoms of intoxication. But patient treat only in a surgical ENT department because sometimes the process progressed and we need external, surgical treatment by CITO. And indications for surgical treatment are development or treat intracranial complications, development subperiosteal abscess, and failure of conservative treatment of the patient. The operation named mastoidectomy or antromastoidectomy, and due to this operation we remove pus and inflamed bone in a mastoid process completely, and after that we perform paracentesis of the tympanic membrane for the drainage from middle ear and suture this area. The patient treated in a surgical department. Of course, we add after operation period antibiotic therapy and prevent other more seriously complication by evidence every day and put the ear drops with antibiotics in external acousticus meatus. And finally, the good results of our operation is a completely healing and hearing restore. But patient in their future life or during examination hasn't mastoid process. It's a result of the operation. No mastoid process on computer tomography in this case, but it's no very severe feature because there is no inflammation in the middle ear, no spreading pus inside in the cranial fossa, and mastoid process doesn't take part in a hearing, and the hearing really normal after mastoidectomy. So we may finish our lecture. Thank you for your attention.
Я смотрел, вы читали вроде.
Да, вот здесь вот выскакивало, что они там отмечались. В этот раз почему-то нет.
Не знаю. Чего их не было. Сейчас. А это какая была аудитория?
3-я.